Welcome, everyone. Thank you for joining us for another podcast episode with THB. Today, we have a special guest, Dr. Suhail Jukhdai, with us in the studio. Dr. Suhail is an orthopedic surgeon in the UK working with the NHS. He's also a telehealth innovator and expert and Chief Medical Innovation Officer at THB, the Health Bank Global. Thank you so much for being with us here today, Dr. Suhail.
It's an absolute pleasure, Zamina, to be here and to talk about my passion, and especially with reference to how the Health Bank Global is going to take it forward. And I'm glad that audience here is going to be joining us as well.
Wonderful. So today the topic is clinical telemedicine. This is a very large and vast subject. We have a few specific questions, and we would love to get your input and guidance in what this concept really is and what it means and where we are heading with it today in the healthcare industry. So starting with, can you explain to the audience what is clinical telemedicine?
You know, this is an opportunity which we are losing by calling video conferencing between doctor and patient as telemedicine. The video conferencing between doctor and patient is video calling between the two people. But clinical telemedicine is the way to manage a disease of the patient. So clinical telemedicine, if I want to simplify the definition before going into complexity, is that how you virtualize a patient and doctor process, meeting process. So when you go to a doctor, you don't just meet. That's video conferencing. A doctor has a lot of other things to do. For example, to look at your medical records, to explain them to you, to make clinical decisions, to follow a clinical decision support system, to diagnose a condition, and sometimes also advise you and show you some educational diagrams, and then give you a follow-up appointment, and then also have a facility for the patient to change the appointment. So all that and much more is the process a doctor and patient meet. But video conferencing shouldn't be called telemedicine because that is just a conversational ability. So I use the term clinical telemedicine when it comes to virtual disease management. And virtual disease management through clinical telemedicine has many components, 34 components. So what I have done at our office in THB, the Health Bank Global, is to list all the things when a patient thinks of seeing a doctor, to the point when a patient says to the doctor, "Thank you, doctor, you've helped me." All these processes are almost 34 in number. And I've virtualized each process and put them in one single code. That's a clinical telemedicine software.
Can you give us some examples of what these 34 processes are? Maybe just one or two, aside from the video conferencing aspect?
Take example of somebody coming with a skin rash to a doctor. So what the doctor will do, will talk to the patient, take a history, look at the medical records. In clinical telemedicine software, the medical records are inbuilt, either from a main server or within that software. And then the doctor will try and examine and possibly take pictures. Now, in normal setups, there is no facility to take pictures. Mm-hmm. But in a clinical telemedicine setup, the doctor has the control of the patient side camera. And remember, doctor and patient are not sitting in the same physical space. So the doctor can control the patient's camera and take snapshots to make a visual electronic medical record. Now that exceeds the physical consultation. So there are advantages in clinical telemedicine which in physical consultations you don't have. So when this patient comes next time, the doctor has given, let's say, steroid cream for the skin rash. So the doctor can compare the last week's skin condition with the current through this clinical telemedicine system of ours.
Mm-hmm. So now that we have a better idea of what this is, why is it something patients should think about, consider, and opt for?
The thing is, the culture of video calling is not a fantasy anymore. It's not a novelty anymore. Skype, Zoom, and all that. So people are now geared to that. And that is where we take off. We should differentiate video calling between doctor and patient than from clinical telemedicine. Because in clinical telemedicine, doctor can actually manage your disease. The doctor has access to your vital signs. If you're wearing some gadgets, if you're not wearing gadgets, you can use the portal on your mobile phone log in into your account and enter the blood pressure readings you've taken today, yesterday, so that the doctor can see on the next visit. So that is where the doctor can really benefit you from the expertise. If in video conferencing, the doctor has a limitation of just taking your history and maybe doing a visual examination. But in clinical telemedicine, he has a lot more clinical tools. And our software, the design is such that on the left-hand side, there are clinical tools. On the right-hand side, you've got educational tools. And in the middle, there's doctor and patient talking.
So it sounds like there are many benefits for the patient, but also the physician in this process. Can you elaborate exactly how this works at both ends?
I'm glad you talked about physician as well. You know, for any doctor, to see the confidence, the joy in the patient's eye is an amazing feeling. Let's say if a patient goes out of clinical consultation on a video and says to the relatives, I just had a call on with a doctor on a video, as compared to, I saw a doctor. Now that feel on the patient side will be transmitted towards the end of the consultation if the doctor has properly mastered clinical telemedicine software. So the patient will feel, in fact, I tell you what, the patients and the doctor will forget they're using a software. The software will become invisible. And that is a success and joy of clinical telemedicine. I'll give you an example of a recent clinic of mine in London. There was a patient who was smoking in front of me on a video consultation, telemedicine consultation. And he said, what are you doing? He said, doctor, I've never had a courage to ask a doctor to smoke in clinic. Now you can see me and I can smoke. And then there was a lady with a cat in the lap and she was kind of moving the hand on the top. And I said, why are you doing that? She said, I'm so relaxed. You come to my home. I can open the door for the postman. I can take the milk bottle while I'm talking to you. And that level of comfort the doctor has to impart to the patient.
So instead of feeling like an inconvenience, it's actually could make you a little more comfortable as a patient rather than feeling like there's a barrier. It feels like your patient said, that you're in their home, essentially with them in a place of their comfort.
Absolutely. You know, imagine the comfort of the patient. Patient doesn't have to go out. There's no waiting time. You don't have to sit in the waiting room and catch infection of others. And the social burden on the patient's family is less, because an old person has to have with a family to go out. A mother has to stop a job, a day work to take some child out. And then there's a waiting time. There is a traveling time. There's a cost of traveling. And it's a lot more greener if there is a paperless clinic. It's a lot more. The cost to serve ratio is very, very efficient for a virtual clinical consultations. People spend 87% more in setting up a clinic facility physically, brick and mortar, as compared to virtual. So there are economic benefits, there are physical benefits, there are psychological benefits. For example, a patient is suicidal. They can't find a psychiatrist in time in physical.
Yeah.
But they can find somebody online next moment. So we can avert a suicide if he or she got somebody to talk to. Patients in postpartum zone, when the ladies get deliver a child, and sometimes they go in depression and they don't even talk to somebody.
Yeah.
That is a time they get consultation on the privacy of their mobile phone, talk to a psychiatrist, and get back to life.
You mentioned so many specialties just now. Could you elaborate on what areas, what type of patient concerns, what type of specialties could really benefit from clinical telemedicine?
First of all, nowadays, with the advent of so much variables, so much sharp investigations, any specialty virtually can be put into clinical telemedicine. So there isn't any limitation. But if you talk about convenience and easy to set up, psychiatry is first.
Yeah.
Endocrinology is second. These two, and the speech therapy, psychotherapy, these three, those specialties which rely heavily on investigations, they are ideal for teleconsultation. So first of all, those rely on the conversation, like psychiatry. The second group is those rely on investigations are the second. And the third, where they are relying on physical examination, but there are tools nowadays which patients can wear. For example, you wear a band on the shoulder, and then as you move the arm out, it can tell you what is the range of the movement. And in my clinics, if I want to examine someone's shoulder, I don't have to touch them. I can ask them to put the hand behind. that is external rotation. Hand behind the back, that's internal rotation. So in clinics, we don't touch patients all the times. We can examine patients by giving instructions. I'll give you one more example. You know the entrapment of the nerve in the wrist, and that gives the carpal tunnel syndrome and numbness in the hands.
Right.
You can examine that by telling the patient to do this. That's a special sign called Phelan sign, which we do in clinics. I can do on video call that, okay, can you do that? Are your hands feeling numb? I never touched the patient.
Right.
But I got a test done, a diagnostic sign of carpal tunnel syndrome done. If your fingers are numb, I can say that if this is 10 out of 10, how much is that out of 10? Did I touch you? I can just get the information out of you. The doctors are the barrier to the clinical telemedicine. It's not the patient anymore.
Yeah.
It's not the regulations. It's not the funding. It's not the doctors have to be confident enough to take it forward.
And you mentioned wearables and devices, and perhaps that's the question that the doctors have, that I have so many, physical or, investigations or tools that I need in a session. But there is a way to integrate that when it comes to clinical telemedicine. Can you tell us what kind of devices have been used in that scenario and what the opportunities exist to add more in terms of connectivity?
Generally, there are 3 kinds of devices. First are the standard manual devices, like a blood pressure kit device, could be digital, could be standard. Now the patients can find the reading and enter into their account into the telemedicine. Any patient who sees the doctor on the telemedicine will have an account, username and password. So you can tap in the reading. So that's one way. The second is the wearables, where you have a Bluetooth version, like which connects to your phone through a Bluetooth connection. And then the Bluetooth can take you to the server. And from the server, the software picks the reading and brings it back to the doctor's interface. So that's a Bluetooth device, which is economical, which requires a little setup, 1 or 2 steps. The third is the cellular device, which requires just the network from the phone, and then it is easy to set up because the moment you put that and you press the button, you connect it to your system. But it's expensive. So that's why they're going out of fashion. And the Bluetooth devices, and I'm wearing one right now for the continuous blood pressure monitoring.
Yes.
So they are the more popular ones.
And the glucometers are also now connected with Bluetooth. So there are many devices out there that fit this model very conveniently in our daily lives. Like you said, you're wearing your devices. We all have our wearables and gadgets we use, and they've become such a key part of our daily life that it's not too difficult to think of clinical consultation and telemedicine as part of our regular feature when it comes to
especially
healthcare.
Zamina, this variable you mentioned, the glucometer, there is a device which we use at the Health Bank Global, where the patients wear on the shoulder like a sticky pad, and this gives us a continuous glucose monitoring. And we at the Health Bank Global on the screens monitor their blood glucose level. So if a patient's diabetes is really poorly controlled, we can do call to action, like a moderate rise in glucose. We can tell the nurse will call the patient, say, well, stop your sweet foods and all that, and then make sure that you take the insulin on time. The next call to action this is advisory call to action, what we do. The second is the interventional call to action, that if the glucose is going up more than 10, GP will call the patient and will say, I want to adjust your insulin. But if it's going more than 25, for example, milligram, then the specialist will call the patient and say, well, I want to adjust your plan. And more than that, we can send an ambulance directly to the patient's home. So advisory, interventional, and critical call to action. That's what we have in the virtual home care.
Absolutely. And one last question for our audience, for them to understand what scenario should they seek clinical telemedicine under? How do they make that decision that it's right for them? How should they approach it? Should they wait for a certain condition or a certain challenge? Or is it something that they can proactively consider? How should they approach that?
It's a great question, Zamina. The tradition has been to manage the disease management. But the focus is now shifting where the education is rising, health management. So before a disease comes, you have signs and precursors of warning or you have a susceptibility. For example, there's a diabetes running in the family, hypothyroidism running in the family. So that is, the person hasn't got the hypothyroidism as yet, but that's the lifestyle management. So you know that you are susceptible to get one. So precision medicine is the next stage, but the Health Bank Global, we are working on both, as you know, lifestyle management and disease management. So we encourage people to come to us and talk about how can they prevent getting diabetes because it's running in the family. So we advise them the nutrition plans, online advice to the nutritionists. But once, if they get the diabetes, then how to prevent the more serious stage. So that is again lifestyle and disease management. But when it comes to disease, then we have doctors managing that point. So both from the advisory group up to the specialist, there's a whole range of help available at the Health Bank Global.
Thank you so much, Dr. Suhail. I'm sure our audience took a lot of key points out of this session. Really appreciate your time today.
My pleasure. Thank you.
I hope you enjoyed this segment today. Stay tuned for more from the Health Bank Global.